back to Ask the Expert. I am your host, Amy Board, and today we're taking a fun ride on the seesaw of science. Picture a playground seesaw. It stays balanced only when both sides are just right. If one side is too heavy, or if one side is too light, down it goes. Inside our bodies, a similar balancing act is actually happening. And it's actually happening between clotting and anti-clotting forces. And when that balance is off, bleeding disorders can occur. As we continue to talk about rebalancing agents, traditionally, if someone is missing a clotting factor, like factor 8 or factor 9, the solution has been to replace it directly. That's like handing the repair crew the tool that they're missing. But what if we helped the crew work smarter, not harder, by removing obstacles instead of adding more tools? To unpack this innovative treatment, I sat down with Dr. Ben and Dr. Patrick, two experts who have walked me through how rebalancing agents worked, what has inspired them, and what this could mean for the future of bleeding disorder treatment. We're also excited to welcome Dr. Singleton, adding a fresh voice to this jungle gym of science. We're going to be right back after this message.
Back when it was first described, if females did have bleeding that was abnormal, they were deemed to be hysterical. It was a medical fact that women could not have hemophilia. And of course, now we know that that is absolutely not true. That has been a huge barrier for women and girls to this day of getting accurate diagnosis and access to care and treatment. Women and girls are not included in clinical trials. And the issue is that if women are not included in the data, that door is never open for them and they don't get access.
I've talked to many women that even can't get doctors, can't even get diagnosed. I want the future generation, especially for women with hemophilia, to be treated the exact same.
We've never done this before. We've never collectively come together to talk about what it is like to be dismissed.
As always, I want to send a big thank you to our presenting sponsor, Sanofi. We could not do this without them, and we are grateful for their continued commitment to educating our community. So again, imagine the body's clotting system kind of like a seesaw. It needs balance. And when that balance tips, rebalancing agents step in. Let's hear from Dr. Ben Samuelson Jones and Dr. Patrick Ellsworth to break it all down.
So the whole idea of rebalancing is that people with bleeding disorders don't have enough of the procoagulant factors. They don't have enough factor 8. They don't have enough factor 9. And so instead of replacing what you're missing, the idea is to remove some of the anticoagulant power. And this is to rebalance it.
The principle is basically to put the thumb on the scale of that seesaw that we were talking about, with that balance, and to kind of say like, well, okay, yeah, you're missing factor 8, you're missing factor 9 or whatever. Let's push that balance back somehow, because there's a lot of these proteins around that can put the brakes on the system. Researchers for a long time have just kind of shot at different targets, seeing can we get this to rebalance hemostasis so that instead of being more prone toward bleeding or not forming a nice fibrin clot, can we form a nice fibrin clot basically or clinically speaking, what you would see is just someone's not bleeding anymore. And the idea from these is, interestingly enough, came from people who co-inherited bleeding disorders and prothrombotic disorders. So if they had had one or the other, they would have either had, just kind of classically, say hemophilia A, or the other one, they would have had like a severe, like an antithrombin deficiency. And so there were some articles going back, and they're probably even before, but, in the 80s, 90s, and then when they sequenced the genome, they saw, oh, well, these people just inherited a copy of each one and they're not bleeding. They're just kind of hemostatically speaking normal, even though they had genetically proven hemophilia A, or I think there were some papers with B as well. And so the researchers had said, well, okay, if this can happen in nature, can we imitate this? Can we try to, imitation being a form of flattery, right? Like, let's flatter nature. Let's try to do what nature has done in these very rare cases. So that approach has been taken by a lot of different groups, and with things coming along in different phases. The furthest along, just in terms of regulatory approval, are these TFPI antibodies.
I also had the chance to speak with Dr. Singleton, who's been closely involved in both research and care around these new therapies. Dr. Singleton is a nationally respected leader in pediatric hematology and an experienced provider for children, adolescents, and adults living with bleeding, clotting, and other rare blood disorders, and we are thrilled to welcome her as one of our experts. Treatment options have widely expanded, bringing fresh hope and exciting possibilities for everyone in the bleeding disorder community. And Dr. Singleton has a terrific point of view when it comes to this paradigm shift.
I would say in general, there's been truly a pretty significant paradigm shift since we started the whole journey in terms of having success and progress and just having additional treatment options available. We didn't necessarily always have available therapies for prophylaxis, especially for inhibitor patients, as that landscape has changed and now expanded. So I find it to be very exciting that we have an opportunity to have these conversations about new and available therapies. From just me asking that question, like, how do we make sure that people are really on prophylaxis? Like, how do we make sure that people just have an opportunity to understand how to prevent bleeding, using factor concentrates, to now we're using words like rebalancing agent. Like, how cool is that?
Rebalancing agents can represent a new way to successfully achieve clot formation, not by adding more factors, but by easing off the body's natural anticoagulant brakes. More from Dr. Singleton.
When we're talking about a rebalancing agent, we are still talking about a way to have a goal, to have a clot to form when we need it. But it's just happening in a different way. So instead of replacing what's missing, we now have an opportunity to think about the entire coagulant system in terms of procoagulants and anticoagulants, because your body has both. And how could we still have the needed end goal results, like the end results of having clot formation so that you don't bleed? How can we have that by looking at the two things that are involved, procoagulants and anticoagulants? And if you're missing some of the procoagulants and the scale is now tipped a little bit, right?
So, instead of piling on clotting factors, these therapies lighten the load on the other side, reducing the body's natural anticoagulants. It's like adjusting the seesaw by easing off the brakes rather than adding more weight.
Like this. So you don't have enough of those procoagulants over here. And so you're heavier, right, on the body's natural anticoagulants, the body's natural defense system, right, to prevent clotting, prevent too much clotting. So you're heavier on this side. So how do you take some of the weight off on this side? Take away some of those natural anticoagulants. So now you do this. And you're now back in a place where instead of having that scale tipped, you're now in a place where you can have clot formation that way. You didn't replace what was missing. You took away a little bit of another part of the system, the body's natural anticoagulants.
So by easing off some of those natural anticoagulants, we bring the system back into balance and allow clotting to happen when it's needed. One important piece of this seesaw is the procoagulants, and tissue factor being a key player and a key trigger in the clotting cascade that sets everything in motion. Here's Dr. Samuelson Jones once again to explain the role of tissue factor.
So tissue factor is part of the coagulation cascade. It's one of the procoagulant factors. It's called tissue factor because it's in tissue that's outside of the blood. And when it's exposed, it makes activated factor 7 start working. And so and I mentioned previously that activated factor 8 and factor 9 work together, activated factor 7 and exposed tissue factor work together in very analogous ways. And so that complex of tissue factor and activated factor 7, that's the trigger that tells the coagulation cascade, you're outside of blood, there's tissue factor around, start working. And that's what then lets you generate indirectly a little bit of thrombin. And then once you generate a little bit of thrombin and thrombin says, okay, I'm not being regulated, I'm going to feed back and make a lot of factor 8, activate factor 8, and a lot of activated factor 5. And I'm going to indirectly activate factor 9 And then we're going to make a whole bunch of thrombin and we're going to stop this bleeding.
Now that we've covered how tissue factor triggers for the procoagulant process, let's dive a little deeper into the body's natural brake system. Specifically, a key anticoagulant called tissue factor pathway inhibitor, or TFPI. TFPI acts like a safety guardrail, putting the brakes on clotting to make sure it happens only when and where it's needed, preventing it from going overboard.
There's also something called TFPI, which stands for tissue factor pathway inhibitor. And so even though the name sounds similar, it does the opposite thing. And so what it does is that initial pathway of when activated factor 7 and tissue factors start kicking off, it blocks that. And so it's one of those ways that the initial signaling trigger to start thrombin generation then is downregulated by TFPI.
In people with bleeding disorders, the balance is tipped because they're missing some key clotting factors. The idea behind rebalancing agents is to ease off that brake by targeting TFPI and other natural anticoagulants so the body can form a stable clot even without replacing that missing factor directly. You may have also heard about fitusiran, a small interfering RNA therapy that takes a slightly different route to restoring balance.
I keep hearing from folks every time I see like a talk at ASH and stuff, they're like, oh, it's coming soon. And that's fitusiran, which is a really cool one it's what's called a small interfering RNA. So for people who haven't done like cell biology, there's DNA, your body makes RNA from that, which is kind of like this temporary copy that then protein is made from. And the small interfering RNA stops that process of DNA to protein, kind of like breaks that on the way, to put it simply. And so fitusiran is a small interfering RNA to the antithrombin from the antithrombin gene and actually decreases how much antithrombin you make. And like I said earlier, that one is just always kind of floating around in our system. It doesn't need a clot or a clot started to start to upregulate it or anything. It's just always there. And people who are deficient that can have some really nasty clots. But if you lower that in people with hemophilia A or B, with or without inhibitors, as it turns out, you can, again, because you're not stopping that initial thrombin generation, you just keep making thrombin. And as it turns out, that works pretty well too.
Another crucial part of this treatment revolution is the patient experience, because with innovation comes a new approach to ongoing care and education. Here's Dr. Singleton to shape how this shift is shaping patient care.
I think, though, that the level of care that's required has only shifted a bit in terms of the cadence. The ongoing communication, the coordination in terms of comprehensive care, the team approach that we have in hemophilia, all of those things I think are still really needed. So it's just a shift in terms of the education and like learning of how to recognize what a bleed is like when you're on a rebalancing agent, when you're on a newer therapy, especially upfront. A plan has to be put in place. And it takes some additional communication and kind of getting the hang of it. And we still have to communicate. We just may communicate in different ways, maybe not quite as frequently. But early on, we have to make sure we get it right. And then whenever there's a question, you should still, in certain situations, especially if something could be potentially serious, treat it and then stop and make a phone call. With the rebalancing agent specifically, we do have a different way of approaching it with the breakthrough bleeding episode, a different way of approaching it from a surgical standpoint.
All right, now let's shift gears and look at another key player in this balance, the natural anticoagulant called antithrombin, which works differently than TFPI. Again, it's antithrombin.
Antithrombin, historically, 30 years ago, we've also called it antithrombin 3. You'll see that a lot. The current name, there's only one antithrombin currently. It inactivates a lot of activated coagulation factors. So I mentioned, it's really important that the whole coagulation cascade can be turned off eventually. One of the ways the coagulation cascade is turned off is by antithrombin inactivating activated factors. And it does this really well with thrombin and activated factor 10. Antithrombin can also inactivate, in certain scenarios, activated factor 7 and activated factor 9. Another way that it's controlled, the clotting cascade is controlled in space, is that inactivation process is accelerated if the antithrombin interacts with heparins, which are often on healthy blood vessels. So you can imagine that if you start clotting where there's a healthy blood vessel, the potency, the strength of the antithrombin inhibition is stronger.
Okay, so think of antithrombin as the cleanup crew. It steps in to shut things down when clotting's done its job. By gently easing off its action, rebalancing agents helps the clotting side catch up and restore that delicate balance. But when we start shifting that balance, lifting off the brakes instead of adding more weight, we also have to pause and ask, are we tipping too far? So let's talk about safety. Because even with these exciting breakthroughs, it's just as important to understand the risks and how we keep a close eye on them.
You may predispose to a little too much from a blood clotting standpoint, right? So you may tip the scale a bit too much, right, in terms of that kind of procoagulant activity. In terms of the clinical trials, we always review safety and efficacy, right? So those questions have been asked and answered in the clinical trial setting. But what you're seeing in real time is once they're approved, those questions are not stopped. We continue to observe indirectly, but also directly with long-term effect studies. And Athens is participating in a lot of those. It's kind of where I come in, where I'm honored to participate. But those observational studies where we're directly watching, recording, safety and efficacy in an ongoing way, even after a product is approved. So that's the big picture of what's happening right now and kind of like the pros and cons associated with it. And so everything isn't right for everybody, again, but it is a significant opportunity with these rebalancing agents to ask questions with your provider to see if something is right for you or not.
In other words, there isn't a one-size-fits-all answer. The math of balancing clotting factors versus anticoagulants isn't in any textbook. Each patient is like a unique seesaw that needs its own calibration. Researchers are working hard to figure this out with experiments and real-world data.
Is it approved for you or not? Are you the right age? Do you have the right diagnosis? Are you the right candidate considering all of your individual comorbidities, right? Like what's going on with you as an individual? And would you be a candidate to receive something to prevent bleeding that's a rebalancing agent as a subcutaneous injection? Because that's what they are, right? You would still need to have factor concentrates available for severe bleeding episodes if they occur, for surgeries if they occur. So you would have to have a plan with your provider if that was needed. But that, again, in a nutshell, would be the kind of pros and cons and a brief intro into rebalancing agents.
So what's the promise here? The future of rebalancing agents is as exciting as it is new. So think of it not as just giving the repair crew a missing wrench. Instead, we are rethinking the whole strategy, helping the system work smarter, not harder.
Clinical development of many of these rebalancing agents, that thrombosis has been observed. Now, it's still a low rate, but it's higher than you'd expect for people with hemophilia not getting these type of therapies. And I think the key question is going to be, does the convenience of these type of therapies outweigh that thrombosis?
And when it comes to answering that question, especially for those with ultra-rare bleeding disorders, it starts with the people living it.
Think about this. If you are living with an ultra-rare bleeding disorder, how do we find you? How do we count you? So if we can't find you and we can't count you, we certainly don't know exactly what's happening to you. So sometimes if there's an observational study that you can participate in and they're a pain, because you have to document how you bleed and how you treated it. And all the things, right? And you have to sit through a consent form and all the things. And we have to open the study and that's painful and all the things. But that's how you change things. You change things by standing up to be counted, by making sure when you stand up to be counted that we know what's happening to you in the real world.
This is where patients come in. By sharing their experiences, by participating in observational studies, and yes, even sitting through long consent forms and keeping detailed records. It's work, but it's also how we make progress. It's how we make sure your story is a part of the data that drives change.
So all the bleeding complications that you're having, who knows about it? Is it being accounted for? We complain as people treating people with ultra-rare conditions and as people with ultra-rare bleeding disorders, we complain, well, all this bleeding is happening and we're suffering in this way and this is happening and hemophilia has all the things. But go back, why does hemophilia have all the things? It's because of the studies that have occurred and the organization and standing up to be counted and documenting what's happening, and then ultimately leading to more research and development. So we have to band together, both as treaters and as a community, to try to figure out in an organized way, how can we stand up and be counted? And how can we document what's happening so we can have real change?
Health equity starts with understanding. Sanofi's global survey of 2,700 participants across 11 countries uncovers critical care gaps for people with hemophilia. Only 30% of patients report adequate care, and just 21% discuss overall health with providers, highlighting inequities in comprehensive care. Furthermore, 59% of caregivers face significant strain, proving unmet needs go beyond patients. Addressing these disparities is essential for equity. Scan the QR code or click the link in the show notes to explore the findings and learn how Sanofi is building a more equitable future for the hemophilia community.
So for some, it's about being part of data collection, and others, it's about fewer needles and simpler management. No matter your driving factor, the results might mean a better quality of life, and that is a huge win. As more data comes in and more options become available, like TFPI antibodies and emerging small interfering RNA therapies, the approach is going to continue to evolve. Each advancement nudges the seesaw ever closer to perfect balance. And in some cases, rebalancing could even become the preferred first-line treatment. So that is our deep dive into rebalancing agents. Therapies that don't just replace what's missing, but thoughtfully ease the brakes to restore balance. Even with these exciting innovations, it's not as simple as tipping the seesaw once and walking away. It takes partnership between science, providers, and patients to keep everything steady. But with every study, every story, every new option, we get closer to a more balanced future. Thank you for joining us. Thank you to Sanofi, and a big thank you to our experts for guiding the way. Stay curious, stay connected, and remember, when we rebalance together, we rise together. Catch you next time on Ask the Expert. Did you know bloodstreammedia.com is your one-stop shop for all podcasts for the bleeding disorders and rare disease community? There, you can find links to the Global Hemophilia Report and our flagship podcast, Bloodstream, with your hosts, me and Patrick James Lynch. Also, check out Flow, which is straight talk about extreme periods, and The Pain Pod, which is an in-depth storytelling odyssey of chronic pain. All this and more on bloodstreammedia.com, the #1 podcast network for rare disease. Have an idea for a future episode of Ask the Expert? Or have a question that you would like to hear one of our experts answer? Email us at mailbag@bloodstreammedia.com. You'll also find Bloodstream Media on Facebook and on Twitter and on Instagram and all those social media channels. I am your host, Amy Board, and until next time, stay curious, my friends.